talk about your position here? I know you're a professor at MCG and what you do at the medical center.
Yes, so I am a professor of medicine in the Division of Infectious Diseases and also in the Office of Academic Affairs. So I spend a lot of time with student issues, teaching them a lot of the COVID work as it relates to students' concerns I've been involved in. And then I've also been involved with patients in the hospital from an infectious diseases perspective.
Okay, and so let's just kind of jump right in. I know when you're in the medical center, there's never a typical day, but maybe walk us through sort of what a typical day looks like in this COVID world, and maybe talk about how that is different from what you saw, 5-6 months ago.
Sure, thank you very much for the question. So the decision was made early on by Dr. Joe Vasquez, who is the infectious diseases division chief, to start a separate infectious diseases COVID-19 service because we didn't want the number of COVID-19 cases to overwhelm the regular infectious diseases consult service where we have responsibilities to training infectious diseases fellows, residents, students. So we had the separate service and we came up with a calendar. So faculty in the Division of Infectious Diseases, including myself, would spend a week or two at a time on the service. The day would usually start at about 6:30 in the morning when hospital administration would fax or text to Dr. Vasquez a list of all of the COVID-19 patients in the hospital, and he would then forward that to the person who was doing the COVID-19 service at that time. And this involvement goes way back to the very early days, the first days of the COVID-19 epidemic. And we were involved over the next 4 or 5 months in a number of ways, primarily though as logistical support, developing policy, making recommendations about which medications should be used, which ones should not be used, who should get them, how early should they get them, and we would then work to establish communications, open communications with the physicians and nurses on the front lines. So we had early conversations with the nurses and physicians in the emergency room. On the floor, the decision was made at the hospital that floor patients would be seen primarily by academic hospitalists, and then of course with the ICU staff. So we typically were not on the front lines in the way that everyone thinks we might have been. We were not on the front lines like the nurses are to this day, nor were we on the front lines like respiratory therapy was, but we did often interact with the patients and especially their families. Families were not allowed to visit their family member if they were diagnosed with COVID-19, whether they were on the floor or in the ICU. And we were involved in getting Institutional Review Board permission to start some investigational clinical trials, or we would be in charge of getting permission from patients or their legally authorized representative to enroll them in FDA-approved investigations of these products, whether it was convalescent plasma or Remdesivir. Remdesivir had the FDA emergency use authorization, but we were the ones that would typically contact the families. And in general, it was, the families were very supportive of that, but not always. And then I understand a lot of these products have side effects. We have to discuss that aspect with the actual patient or the patient's legally authorized representative, especially in the case of somebody who is intubated and sedated in the ICU. So that was, in a nutshell, what I was doing and my colleagues were doing on a daily basis. It was not so bad at first. Once we got any chaos out of the system once we got everybody to understand the approach. The ICU staff, as well as the hospitalists, knew what to expect. They knew typically the patients that would be eligible to receive some of the monoclonal antibodies we were using in an off-label way. We developed algorithms to help them with that. And it wasn't really overwhelming until the last month or so. So for instance, on June 6th, the total COVID-19 census in the hospital was 12 patients, about half in the ICU and half on the floor. And then just yesterday, the census was 72, and it's been at 72 for about 2 weeks now, which is a six-fold increase in about a 7 or 8 week period of time. So we were fortunate that we didn't have a shortage of ventilators. We didn't have a shortage of PPE, the protective equipment. We didn't have a shortage of ICU beds or hospital beds. But what we really felt an impact on was in the nursing staff. Mm-hmm. It was very difficult, especially during the surge, to have the nurses come in. We got permission from the hospital to hire temporary nurses, to authorize overtime. I wasn't involved, of course, in those decisions, but I just want to give a big shout out to the nursing staff for their continued commitment to taking care of the patients in these very difficult times.
Well, yeah, and so maybe talk about, so in working with the nurses, you really see sacrifice. You see what they're going through. Maybe what does that look like right now?
Well, I've been in contact with the nursing administration, working closely with Miss Carol Brody, who was one of the nurse administrators, and she sent me an email that it's pretty rough. It's mentally and physically exhausting, and the nursing staff is really feeling it. Some of them have gotten exposed to COVID-19 and have turned positive. That takes a toll on the nurses as well as their families. They're doing a really great job, but it is taking a toll. We'll find out more. I'm working with Ms. Brody and others, other faculty here at the Medical College of Georgia, to put into place, once we get Institutional Review Board approval, a nursing survey, a mental health survey for the nurses. We want to know what they've been through, what their thoughts are about all of this, and how we've done have we done a good job? Have we communicated in an open manner with them? We won't know those results for a couple of months, but we definitely are looking into it.
Mm-hmm. And so this is so pervasive. It has taken over conversations. It's taken over professional life, your day to day. How do you sort of detach? What's it like to go home when you're in the midst of this?
It's good to go home. It's good to relax. I then start back into looking at emails that have come up through the day. I start planning out the next day, and I am ready to receive phone calls. I get phone calls at night, especially now, from students. We've brought our students back, as the dental college has done as well, and they're concerned. They may have exposures. They may have exposures or potential exposures in the hospital or out in the community. And so they have to have a mechanism put into place where they can express their concerns, get their questions answered, and of course, get tested, and if necessary, self-quarantine and attend class virtually.
Mm-hmm. So when you're working with students now, you've got, what are some of the teaching opportunities that you have with this that you wouldn't have had before, and how do you balance that sort of care for the student as well as having them sort of exposed to the front lines of this?
Right. So the decision was made early on that the students in their clinical years, the 3rd and 4th years, would not have any contact with known or highly suspicious COVID-19 patients in the hospital settings. However, they have come in contact with some patients in the clinic setting, So we have to tell them how to put on the protective equipment and what to do. The students are very, very interested in COVID-19. They're interested in everything about the pandemic. We've put together Dr. Douglas Miller, Dr. Catherine Martin, Dr. Dan Ron, and others at MCG have put together a very well received pandemic medicine elective, which the students, all three classes, second, third, and fourth year students took. It was an elective. They didn't have to take it, but it was very successful. And then I actually gave the incoming first year students their first ever lecture on Tuesday of last week, 1 week ago. And it was about, as you might imagine, COVID-19. The science behind it, the epidemiology behind it, as much as we know about it. And they are very enthusiastic. The first year students want to be here. They want to be doctors. They're proud of their accomplishments. They're looking forward to the year, and so are the second year students, as well as the third and fourth year students now. But there is fear, there is concern. We've all sort of gotten used to doing things virtually or remotely, and now we're bringing students back. The undergraduate campus is about to open within the next couple of weeks or so. They're bringing students in, and the epidemic is certainly not going to go away by that time. So we have to learn, all of us, to wear a mask, especially when we're inside in the classroom. And we have to learn about good physical distancing. And if we all do that, most of us feel that we will be able to continue some mix of in-person and virtual classes.
You talked a little bit about your experience dealing with the families of the patients. This is a unique situation in that a lot of times the families aren't able to be with the patients when they're in the hospital because of the things that are going on. What is that like for you to deal with the families? You talked about the number of increasing cases. To talk with these families who are going through all of this, going from family to family to family.
I feel very fortunate to have had the opportunity. I found it to be an uplifting, very good experience that I can reassure them. I can give them information. Other doctors in the hospital, nurses as well, have been in contact with the family members. And I think that really helps ease the family through the very difficult times, not only in what's going on outside, but what's going on with their family member. Most of what I would talk to them about would be these investigational products, the newer products, but I could also take the time to give them an update, which was typically relayed to me by the hospitalists or the ICU staff about how they were doing. I would always start the conversation by saying, there's not been any change. There's nothing that's, or if I left a message on their voicemail, it would be, this is nothing urgent. It's not an emergency. Call me back when you get a chance. Of course, I would identify myself, but I didn't want them to think that there was something wrong. It's often a very difficult emotional experience for anybody to get a phone call from a hospital when their family member has been hospitalized. Everybody assumes it's the worst.
When you're dealing with patients, or you're talking with the nurses that are dealing with patients, maybe talk about how that interaction with the patient is different now, as far as the protective gear that you have to do, the time it takes. You can't just kind of walk in, talk to the patient, and leave. There's a lot more going on now.
Well, there is. We go in as we are needed. We do our jobs. But for instance, in the ICU, they have been able to pull all of the intravenous pumps out of the rooms of the patients. They use, of course, long extension tubing. So in the ICU, the nurses don't have to go into the rooms as frequently to push the buttons on the pump to make the pump stop beeping or to restart it when necessary. All that is done outside of the rooms. There's still a lot of exposure risk, especially in patients undergoing intubation, undergoing a look into their lungs, bronchoscopy. We increase the level of PPE use under those circumstances. We also have nurses and others observing to make sure that the person going in, the person at highest risk, is putting on the PPE correctly and taking it off correctly, so as to reduce the chance that they'll get exposed.
Mm-hmm. That's got to add a lot of extra stress to an already stressful situation.
Yes, it does. Of course, the patients in the ICU are typically, not always, but typically intubated and sedated. On the floor, the patients are very appreciative of our help, and they understand. They understand that the nurses and the doctors are at risk of acquiring it from them, but we are there to help them through it, through this very difficult time.
What's been the hardest personal challenge for you through all of this?
It's changed over time. Personally, I was concerned, like everybody was at the beginning, that I was at great risk. We were not certain how well the regular surgical medical masks worked. We didn't know anything about cloth masks, which we're still not wearing when we are seeing the patients, but the data now are coming out that cloth masks are very effective. So initially there was concern that I would get infected, that I might spread it to my family members. They were concerned for me. Many of us would, well, in fact, some of the emergency room staff for a 2-week shift, for instance, chose, in fact, to spend the night in a hotel so as not to potentially bring home the virus to the family. I didn't do that. Many of us, however, would remove our clothes once we got home and change into something else and immediately wash those clothes. I don't think that's still going on. So now that the epidemic has surged, the challenges are different. Now it's a matter of whether there's enough time in the day to adequately tend to all of the work that we do in infectious diseases behind the lines, communicating with the doctors on the front lines, communicating with family members, and more than what I'm doing is communicating with the students, the faculty, the deans, and it takes a toll on all of us. It's a big personal challenge. The rest of the work hasn't stopped. This is additional work. I personally am happy to be part of it. I wouldn't want it any other way. I am older, as you can see from my hair, so I would be in a category of somebody who is at higher risk for complications from COVID-19, but I wouldn't want it any other way. I want to be part of this.
Well, yeah, and so what you said about being at greater risk, that strikes me that, you know, there's a lot of sort of unseen but kind of heroic decisions being made. I mean, you know, you're balancing your well-being, your family's well-being, maybe increased risks that you have because of pre-existing conditions or because of what you're doing, but for the greater good of taking care of patients, especially as things surge and everybody's being, you know, inundated with all this extra work. Maybe talk just a little bit about what that feels like, that sort of rising to the challenge in this time of adversity.
Well, I don't want to say that it feels good. I'm glad I am well trained and prepared to handle it. I've been involved in other epidemics before. I was involved in the first SARS epidemic that took place in North America, primarily in Toronto. I was involved from the very beginning in the HIV epidemic. And of course, I've lived through, as an infectious diseases physician, the Ebola epidemic, although I was not involved in the care of anybody with Ebola. So I'm fortunate, I'm grateful that I'm well trained to handle it. Students have asked me in one way or another if this is an exciting time. Um, and I have told them that I wish that COVID-19 never happened. I wish it would just go away. I really do. I don't need to live through another pandemic. Um, and it's going to be some time before it does go away, and it's going to be some time before we have appropriate effective therapies or an effective vaccine. So what I'm taking great um, comfort in and happiness from is the number of individuals now who are wearing masks. I was in Atlanta just about a week ago, and even outside, pretty much everybody is wearing a mask and maintaining an appropriate social distance. Students are wearing masks, faculty are wearing masks, they're wearing masks outside as well. And that's what we've got to do to get this epidemic under control. The surge this time in Georgia has seemingly plateaued, but it's going to take a while until we get back down to where we were in early June. But what will make a difference really are the masks, and that brings me happiness that people are taking it seriously.
Mm-hmm. Just a couple more questions. You've been really generous with your time, and we really appreciate it. What do you think, what's maybe the one thing that people on the outside just don't realize about what you guys are going through? Maybe a misconception or just not knowing?
Well, they probably are unaware of how many individuals have really stepped up to the plate to make a difference, how many extra hours they've worked to make a difference. I think there's a general sense that we're working hard, but they probably aren't aware of the details, and that's fine. One doesn't need to know the number of hours that any of us works, but I do want them to know that we are working very, very hard, doing the best we can to get through this and to get their family members discharged from the hospital in good shape.
Mm-hmm. And last question, is there anything that you want to, you talked about the importance of wearing masks, obviously, but anything that you really want to emphasize or make sure people see or understand?
We're all in this together. We have to work together. We have to do what we can to protect others from ourselves and to protect ourselves from others. And that requires not only wearing masks, not only maintaining a social distance, but at least for now, avoiding crowds.
Mm-hmm. Okay, well, I really appreciate your time. Thank you so much.
Well, thank you, and thanks for the opportunity.
It's been great talking to you, and be safe.
Thank you. Okay, thank you very much.